COVID response banner. Before I move on to the session details, I would like to announce that due to some technical error, we could not upload the voice recording of the last session, but the presentations are still available on our YouTube channel. Today's session is about safety measures to protect healthcare workers and patients against COVID-19 in journal clinical practice. Today's session lead is Dr. Adeel, who is a professor of medicine and professor of healthcare policy and research at Weill Cornell Medical College, and also vice chair Department of Medicine and director clinical epidemiology research unit at HMC. He is also the president of CEO of Innovations in Healthcare Advocacy Research and Training iHeart in Washington, DC. Dr. Adeel's work in education and training experience spans several countries in all the 5 continents. He is recipient of numerous national and international awards. He has lectured extensively and provided consultation to several governmental and non-governmental organizations in building research, educational, and training capacity in resource-limited settings. So without further ado, I now hand over to Dr. Adeel.
Thank you, Kiran, and Assalamu alaikum. Let me share my screen and tell me when you can see my full screen, Kiran.
Sir, not full screen now. Yes, we can see.
Okay. Thank you. So first of all, I would like to thank ECHO and PARSA Trust for arranging these set of very useful seminars. Even I learned a lot from these. And I also want to thank all the participants who take the time out and attend these. I will move quickly today because we want to spend a lot of time in answering questions later on from the participants. I have no disclosures for my talk today. And the objectives today of my talk are very straightforward and simple. I'm going to talk about how to minimize risk to yourself, your staff, and your patients in the era of COVID-19 when you open your practices. And this talk is basically focused on general practitioners. There may be a few questions which may overlap or a few points that may overlap with others, but basically focused on general practice. But before we go on, I just want to share with you and dispel some of the common misconceptions about the seriousness of the situation and seriousness of this disease. Now, a lot of people on social media have been saying that, well, COVID-19 is not that serious, we will get over it, there'll be herd immunity, when the temperature goes up, cases will go down, etc., etc. But remember, it is a serious disease, and I've listed some data where you compare COVID-19 related statistics with the other 2 coronaviruses, the MERS-CoV and SARS. And as you can see that we have thousands of folds higher number of cases of COVID-19 worldwide. The number of people who have died from COVID-19 is 500 times more than MERS-CoV and SARS-CoV. However, fortunately, case fatality rate is still lower than MERS-CoV and SARS-CoV, although it is at least 10 to 100 times higher than influenza virus. And the situation in Pakistan, you're all aware of, the cases are still rising, and the projections are that they'll continue to rise and the deaths will continue to rise as well. To understand and implement some of the safety measures, we need to understand the ways the virus is transmitted. And virus is transmitted from surfaces in terms of, or in the form of droplets. And it is important to know that the virus can survive on various surfaces for many, many hours. On copper surfaces, it can survive up to 4 hours. On cardboard, up to 24 hours. On plastic and stainless steel, 2 to 3 days. And even in aerosols, when you cough or sneeze, it can stay in the aerosols for up to 3 hours or so. And live or viable virus can be isolated or detected. There was some confusion about whether asymptomatic people transmit infection or not. There was a video by one of my WHO colleagues. Now, the bottom line is that asymptomatic people can transmit disease, although it may not be as high as previously thought, but they can transmit infection. Now, since we're talking about protection of healthcare workers, what are the risk factors for picking up COVID-19 infection for healthcare workers? And the strongest risk factor is having a family member or a close relative who has been diagnosed with COVID-19. That is the strongest risk factor for a healthcare worker to become infected. Having a patient who's confirmed COVID-19 is not as big as risk factor. In fact, that has been shown to be relatively protective. And I think the reason for that is when we see patients in the hospital, we are extremely careful. We put on PPE, we put on masks, gloves, gowns, face shields, and so forth. But when we are with family members, we do not take those precautions. And I will touch upon that later on in the talk as to why that is important and how we can minimize some of that risk. And also wearing improper PPE or wearing it in an incorrect fashion and not performing hand hygiene properly are very, very strong risk factors for doctors and nurses and other healthcare workers to pick up infection. The big question these days is, should people wear masks or not? Are masks protective or not? Which type of mask to wear? And this is a very influential study, although it was a small study. It was published in Nature Medicine. It looked at the chance of infection with or without a surgical face mask. This is not an N95 mask. This is a simple but good surgical face mask. And I've summarized the study out here at the bottom in the blue bar. For droplets which are more than 5 microns, if you were not wearing a mask, the chance of transmission was 30%. If you're wearing a mask, the risk of transmission was 0%. For aerosols less than 5 microns, without mask 40%, with mask 0%. These and other data are quite convincing that we should be wearing masks in a pandemic situation so that we can protect ourselves and we can also protect others from infection. So how do we prevent ourselves in healthcare settings? So there are 2 basic principles of this. One is to prevent yourself from getting infected, and second is to prevent transmitting it to others, either from yourself or one of your patients or colleagues who has the infection. If you do these 2 things, then you can go on to save the rest of the world. And we need to break the cycle. And how do you break the cycle of transmission? There are 4 basic pillars of this: social distancing, enhanced hygiene, travel restrictions, and gathering restrictions. And I think these are all very self-evident. In social distancing, no handshakes, no hugs, work from home as much as possible. In terms of enhanced hygiene, you do have frequent hand washing and sanitization, proper cough etiquette, and you clean the surfaces in your offices and homes frequently and with proper solutions. Travel restrictions include targeted or wider lockdowns, and you must restrict travel to what is absolutely necessary. Gathering restrictions include avoiding malls, restaurants, weddings, funerals, mosques, any place where there's a large number of people from different areas which gather together whose infection status is unknown. And these public health measures do work. No matter what some politicians may say or some people may say on social media, the countries which instituted these measures strongly, they showed a very, very sharp decline in transmission of infection, and they were able to control the epidemic very quickly. And these are examples of how they were able to do that. As soon as they instituted some of the measures, public health measures that I mentioned in the last slide, the infection rates went down. So let's go on to the main part of the talk, which is workplace adjustment. So what can you do in your clinics? So some general principles include that you should minimize your clinics till the pandemic is under control. Limit seeing patients to those who are in strong, urgent, or critical need. Use technology wherever it is possible, like telephone, video calls, telemedicine, and so forth. And if there is no other option and you have to see the patient because either the patient is critically ill or there's no fallback, then take all the precautions regarding infection control and infection prevention. And we will go over that. Some of the things to consider before opening your practice are listed out here, and this slide all these slides will be made available to you, whoever wants them. So you minimize chance of exposure for your staff, patients, and visitors, strict adherence to standard precautions, and you enhance those practices when needed. You adjust patient flow, patient placement in your clinics or in your hospitals. You control access or entry into your facility and movement within the facility. There are some engineering controls we'll talk about, policies and procedures, both for exposed or affected staff, as well as for patients. And of course, it is very important to make sure that we report to appropriate public health authorities so that they can take appropriate measures. What kind of workplace realignments can we do? So there are 3 main things that are important in terms of workplace realignment when you open your clinic or your practice. These are administrative controls, personnel or human resources controls, and engineering controls. In administrative controls, if you own your practice or if you are the administrator of a hospital, you need to have policies and procedures in place for quick identification of people who may be infected, either staff or patients. Make policies of allowing people to work from home whenever it is possible. Make a policy about PPE use or mask use or sanitizer use, and ensure there are enough PPE and hand sanitizer available for people coming in. Personnel or staffing control includes if you can stagger the shifts, if you have the ability to do that. Create physical distancing between staff and patients. Avoid or discourage use of other staff's phones, desks, and equipment. In Pakistan, we have this habit of going to someone else's desk, picking up the phone, picking up their desk phone or things on their desks, etc. These should be avoided. If you have a water cooler, make sure that people don't gather in that area. The glasses are separate and disposable if possible. In engineering controls, create ventilation and airflow. If you don't have HEPA filters or if you don't have negative pressure rooms for infected patients, what you can do is you can open up the windows if that is a possibility and increase cross ventilation. Enhanced cleaning includes disinfection of surfaces, equipment, using approved products. And you can also do changes to the waiting room and exam room layouts so that you minimize people sitting together or close together or interacting with the staff in very close proximity. So how do you translate that into practical measures? So there are 4 steps that you can do for your practice. So general precautions are obviously there that I mentioned before, but the 4 steps here are things you can do before the patient arrives to your clinic, once the patient arrives at the clinic and before you have seen him or her, when they're in your examination room, and what you can do after the clinic is over. So in terms of general measures, we talked about work from home policies. You need to train your office staff how to screen patients with possible COVID infection, whether this is by a small questionnaire or using portable thermometers and so forth. You need to have some sort of a policy around periodic screening of your staff and perhaps even patients, and have a plan for those who may test positive. And these plans include how will you transport these patients to a facility which takes care of COVID patients? How will you do contact tracing and testing? How will you counsel your patients and have measures of deep cleaning once they are identified? You should also have access to identify and prepare an isolation facility, because it's not a matter of if, it's a matter of when a patient or a staff member will be positive, and you'll have to take care of these steps. So even before a patient arrives into your clinic, you can do certain things to reduce the risk. If you have their phone numbers, if you work by appointment, you can call, ask if the patient is symptomatic of COVID, if they have a fever, cough, shortness of breath, and then on the phone, determine if they really need to visit you, if they have these symptoms. Determine the urgency of the visit. If you think the visit is necessary, tell them about the new rules and etiquette. Example, that if you come in, you'll have to wear a mask. If you come in, you may have to wait outside if there are too many people in the waiting room. You may have to use hand sanitizer and all those things that you put in place. If possible, if you give appointments, space out appointments between patients so that you don't have a lot of patients at the same time in your waiting area. You can also redesign your waiting area. If it's very small, see if patients can wait outside in their car. If there is for example, a lawn or a park outside nearby, they can wait out there, or in a parking area, parking lot, etc. Wherever there is open space and they can be physically distant from each other. In your office, limit the points of entry and flow so that people are not just walking through in and out, causing unnecessary risk to others. So once they've arrived at the clinic, and even before you see them, you can have these visual signs or posters which could be educational about how to protect themselves. If they have signs of or symptoms of COVID, they should tell the staff immediately. You can also have leaflets, or if you have a TV and a video player in your office or waiting area, you can have educational materials playing out there regarding precautions. You must have sanitizers at all points of entry. or hand washing basins within the waiting area. You should have told patients to wear masks. You should have signs saying that if you need to enter the waiting area, you must be wearing a mask. Some people may not have a mask, so be prepared to give them a mask or provide them a fresh, unused new mask. A limit number of attendants coming with the patient. If the patient can walk, talk, and give history, etc., no one really should come in with the patient. If they are in need of help, maybe one person at the maximum can come in with them. As soon as they enter your clinic, someone should do a quick triage of symptoms, temperature, and history of confirmed contacts, and then determine how this patient should be handled. You can also install physical barriers like glass or plastic screens for your frontline workers like cashiers, appointment clerks, your secretaries, and these should be cleaned with appropriate disinfectants very, very regularly. If possible, you can also make a triage station outside the clinic waiting area. This should be done only if you can make sure that the patient confidentiality will be preserved, and also it will not increase the risk to other people in the general area. And as I mentioned before, you should have enough supply of masks and gowns, sanitizers, etc. for everyone. When the patient is with you, make sure that there's only one patient at a time with minimum attendance or no attendance at all if possible. You as a doctor must have a mask on. The patient should also have a mask on unless you need to examine their mouth or nose. Except for the time when you need to examine them, you should keep a distance of at least 6 feet if your office space allows that. Minimize your exam to what is necessary. I think these are emergency situations. So what we used to teach in medical schools, that you need to examine every patient from head to toe, is not necessary at this point in time. So you do a target exam, which is really necessary. And if you're using equipment like stethoscope, otoscope, ophthalmoscope, anything that touches the patient, that should be disinfected before and after each patient. Wherever possible, use disposable items. And now you even have disposable stethoscopes that can be used and discarded at the end of the day. This is a slide showing the protective equipment that needs to be used if you have a confirmed case. So for confirmed cases, both CDC and Public Health England recommend using a face mask, an eye shield, head cover, an disposable isolation gown, gloves which do not need to be sterile gloves, and a shoe cover. And there is a specific way of wearing them. So hopefully most of your patients will not be confirmed positives, but you should still have a protective equipment, because you never know if there is an asymptomatic patient or an undiagnosed patient in your practice. Once your clinic is over, what do you need to do? So we recommend that you should have a separate set of clothes and shoes for your clinic and hospital. When you leave your home, after you left your main door, you should have some area possibly where you can change. Whether this is like an outside room in your house, or before coming to the hospital, or within the hospital before you start, or in your clinic before you start seeing patients, wherever you can change your clothes and shoes. You should change them. You should change back into your home clothes before entering your home, just like you changed when you left your house. And if there is a possibility, if you have a home that allows you the luxury of taking a shower and disinfecting yourself before entering the home, you should do that. And store your work clothes and shoes outside the main home. Don't bring them into the house. You can put them in the boot of your car, or you can put them in an outside room or a watchman's room, or outside the house, wherever it is possible, in a plastic bag, for example, but don't bring them inside the house. What if a staff or a patient turns positive? So you should immediately isolate the case. You should evaluate for severity of disease. If the patient has pneumonia, there should be full decontamination of all the surfaces the patient may have been in touch with. Do contact tracing of everyone the patient came into contact with. And you may need to close the facility till all deep cleaning is done and the contacts have been traced. We close our offices for 1 day or overnight for deep cleaning by professionals if we ever find out that a positive case was in that area. So in summary, to protect yourselves and your staff, we should minimize contact to absolute minimum, to those where it is absolutely necessary and patients really need to be seen. If that becomes necessary and you have to see those patients, then take as many precautions as you can. You need to educate your staff and your patients, and you must plan in advance for the possibility of cases both in your staff and in your patients, because they will be positive sooner or later. So what I'll do is I'll stop here. I promised ECHO team that I won't take more than 20 minutes, and it's dot on the 20 minutes. So this gives us a lot of opportunity to answer questions that people may have. So let me stop sharing my screen. And back to you, Kiran and Asad.
Thank you. Thank you, Dr. Adeel. I know it's very difficult, or there will be a lot of questions. Before we move ahead, as we have always been doing before for the ECHO sessions, and we have already started our helpline for COVID patients. So we just briefly share a case because we will all be learning from each other. ये case वो हैं जो primary care के cases हैं, और इसमें आपको बहुत सारे सवालों के जवाब मिलेंगे, और उसके बाद हम लोग इसमें जो डॉक्टर अदील से रेलिवेंट जो भी क्वेश्चन है, आई एम श्योर आपने बहुत सारी बातें की हैं, वो पाकिस्तानियों को बहुत सारा इस वक्त होगा कि वो कितनी चीज़ें हम कर सकते हैं, और जो ग्राउंड रियलिटी है वो it's not the same as in the West or in a first world country. I will request आपके जो भी burning question है, you can just share it in the chat so that we can pick up and take the question. For case presentation, Dr. Kainat will be presenting the case. Can we share the case, Uzair and Kainat? You start presenting the case.
Yes, sure, sir. Dr. Kainat, are you with us?
Yes, Uzair.
Please carry on. Go ahead.
So we had a patient who is a male, 38 years old. He's a non-smoker and non-alcoholic. He have no comorbids and is on taking no regular medicine. His presenting complaint is that he had fever from 1 week, which was associated with sore throat and dry cough. Symptoms have settled from 4 days. Currently, his only active complaint is loss of smell from 3 days. The patient is now afebrile and asymptomatic. Patient was advised COVID-19 PCR, isolation, and to start tablet paracetamol, TDS, and multivitamin once a day. So my question is that should the patient take paracetamol in TDS even when he is afebrile, and does he need any other blood test at this stage? Or should we recommend any antibiotic to this patient? And lastly, when the patient should come out of isolation?
Thank you, Kainat. Basically, it's a mild disease case. Patient is now afebrile. He had fever a week back, and no symptoms now. Symptoms have settled. The fever and dry cough has settled. He's only complaining of loss of smell. So we recommended COVID-19 PCR, but the questions are, should we go for more tests? Is paracetamol really necessary at this stage? And about the isolation. I think Farooq is here. Farooq, we just give Dr. Adeel some rest. If you can answer the question.
Yes, I can. Assalamu alaikum, everyone. Mild case, no. Antibiotics, no. अच्छा, मुझे किसने बताया है ये कि social media पे there has been some disagreement or some annoyance by the fact कि मैंने antibiotics use करने को मना किया है. I haven't seen it myself, but apparently there is, and I think that's very understandable क्योंकि हम लोग our threshold of using antibiotics are relatively low. लेकिन इस patient में in particularly, I will not really I wouldn't even recommend paracetamol, to be fair. Consider paracetamol's half-life, number one. Number two, why are we giving paracetamol? This guy has been Kiran, Kainat, how long he's been aparaxial for?
From 4 days, and now his the fever has settled.
Yeah.
From 3 days.
Yeah. So there is really no need for him to take paracetamol anymore. He has not even temperature really. अच्छा दूसरा, always remember, जो मैं आप लोगों को बार बार ये बात कहता होता हूँ कि just bear in mind the life cycle or the disease cycle what the patient goes through. हमारे एक थोड़ा सा misconcept है कि जिस दिन patient को पहले दिन temperature होता है ना, we assume that that's where the cycle, it isn't actually not that. The fact is that that's probably his day 5 or day 6 in the cycle. He has been exposed at least 5 days, if not more, before to that virus. There is some evidence that people can have expressive symptoms or disease progression in less days than that, but by and large, exposure, you then remain asymptomatic for a few days, you then pick up symptoms. मैंने आप लोगों को पिछली स्लाइड में बताया भी था, there was a very nice study done who looked at survivors and who looked at non-survivors, and it's usually day 8 to day 12 of their disease when they really go into serious trouble. And the patients who go into serious trouble, they actually go to serious trouble very, very quickly. It all happens within 24 to 48 hours as you start to have temperature, more temperature, CRS picture, multi-organ failure. So your patient, particularly this one, if he has been asymptomatic for 4 days, he's probably your day 12, day 13 currently at this point. So not only the fact that he is your 55% of mild symptoms, he's clearly not 30% your asymptomatic one, which encompasses your 85% of patients. He is amongst those 55 जिसने mild symptoms express किए हैं, but he has grown out of it. इसको इस वक्त ना antibiotic चाहिए, ना इसको इस वक्त paracetamol चाहिए. अच्छा, does he need to make any changes to his diet? No, not necessarily, but hydration इसको जरूर रखनी है. ये आप लोग please advise करो. And for isolation part of it, इसने अपना PCR, did he actually have a PCR Kana?
Sir, no, sir, we have advised PCR, but we are waiting PCR.
Okay, that's fine. So isolation से इसको कब बाहर आना चाहिए? Number 1. दूसरा क्वेश्चन ये है कि क्या इसको आइसोलेशन से बाहर आने के बाद भी कुछ ऐसे मेजर्स हैं जो करने चाहिए जो हम एज हेल्थ के प्रोफेशनल्स कर, उसका आंसर क्या है? And yes, he should really come out of isolation at day 14. इसलिए ये बहुत relevant है कि आप ये workout करो कि इसको कब हुआ था. जब number 1, number 2 मैं आपको एक और बात बताऊं, PCR आप लोग please advise मत करो until unless patient has symptoms for 2 days. The maximum pickup, patient से ये पूछ लें आप कि आपको symptom कब शुरू हुआ था. The maximum pickup for PCR, the sensitivity of a positive PCR in a COVID patient really starts after 36 hours onwards of his symptom onset, not his exposure, if that makes sense. तो जब वो symptoms के साथ वो आपको contact करता है तो उससे पूछ लो आप कि आपको symptoms कब से हो रहे हैं. अगर वो कहता है हाँ जी मुझे 2 दिन हो गए या मुझे 36 hours, then that's fine. आप उसको PCR advice कर सकते हो. That's where his maximum chance of being positive begins. अच्छा, now how do we finish? कितने मैंने PCR करवाने हैं? So the answer to that is कोशिश करें कि day 13 या day 14 पे आप उसका PCR भेजें. अगर first PCR negative आ गया है उसके 6 घंटे के बाद please दूसरा ना भेजें. Why? There's a 78% specificity of PCR being negative. So इसलिए कोशिश करें कि at least 24 to 48 hours का gap दे दें. अच्छा, then you can ask him to stop isolation after the second PCR should you have the facility of. जब वो isolation खत्म भी कर रहा है ना तो kindly उसके 1 हफ्ते तक उसको advise करें कि वो gatherings में मत जाए. Number 1. Number 2, वो mask मत उतारे अपना. तीसरा, मैंने आप लोगों को एक स्लाइड शो किया था कि although के viral particles in stools they remain really low and therefore, but interesting चीज इसमें जो 9 पेशेंट्स की मैंने आपसे स्टडी शेयर किया था उसमें एक्चुअली उसके स्पूटम में वायरल पार्टिकल्स कम हो गए थे, नेज़ोफरेंजियल स्वैब्स में कम हो गए थे, बट डे 21 तक उसके स्टूल्स में रहे थे. तो उस मकसद मेरा कहने का ये है कि उसका बाथरूम उसको कहें कि वो अलग ही रखे अगर वो रख सकता है. अच्छा, we know we are resource limited country, हमारे हर patient के पास attached separate bathroom नहीं है, तो उससे कहीं phenyl होती थी, जब मैं पाकिस्तान में था उसमें phenyl होती थी, अब मुझे नहीं पता वहाँ पे होती है नहीं, एक और दूसरा bleach, हम लोग यहाँ पे इंग्लैंड वगैरह में bleach बहुत frequently use करते हैं, so bleach उन surfaces पे use करें toilet use करने के बाद, so these are very small चीजें जो आप उसको एक हफ्ते तक कह सकते हैं। दो बहुत important बात, सो डे 21 जब वो बाहर भी आ जाए तो पहले एक हफ्ते तक वो कोशिश करे कि वो उस कमरे में ना बैठे जिस कमरे में छोटा कमरे का साइज हो और 2 या 3 से ज्यादा लोग उस कमरे में उसके अलावा मौजूद हो। और अगर ये इसके कोई हल नहीं है, कोई तरीका और कोई नहीं है, तो कोशिश करें कि अगर वो एसी में भी बैठा है तब भी कमरे की खिड़की खुली हुई है। दिस इज वेरी रेलेवेंट। अगर उसने फैमिली के पास जाना भी है तो कोशिश करें बाहर बरामदे में चला जाए, लॉन में चला जाए, बाहर मिल ले, बंद कमरे में ना मिले। And yes, after 21 days, I think then he's very safe to carry on. But I will still suggest there is no harm 2 weeks of isolation and 2 weeks of precautions post-isolation. Thank you.
Thank you, sir.
Zach, can you share the second case?
I guess we were to discuss the only one case.
Okay.
Thank you.
Thank
Okay.
you. I would like to request Dr. Busha to take over the questions, please.
Thank you, Uzair. There are quite a few questions in the chat today. The first question is about, although Professor Altaf has already answered that question, since Dettol is not available in the market, what second solution can we use? Clearly elaborated on it quite a bit, but Dr. Altaf has given the Clorox, bleach, and manufacturer's recommendation as 1 in 9 dilution. So, didn't hear?
Yeah, there was a problem with your audio. So the question basically is that Dettol is hardly available in the shops these days. So what else can you use? So any bleach solution, as Farooq mentioned, Clorox is one preparation that I see in the market. Phenyl, as mentioned by Farooq, is available. So all these are bleach solutions, but the important thing is that do read the dilution instruction by the manufacturer. Some of these products have different dilution, techniques. So usually it is 1 in 10 or 9 parts of bleach solution and 1 part of bleach solution and 9 parts of water. But it may vary from prep to prep. So do read them. Thank you.
Dr. Farooq, there's another question for you. Can you hear me now?
Gigi, I can, yep.
Please give a recommendation for need, reliability, timing, specificity, and sensitivity of the antibody test.
Okay, so we have covered it last time, and this is also going to be covered. जो Q&A session असद ने कहा है ना मुझे करने के लिए in 3 days time. अच्छा, antibody
and there
test
will be
related...
Farooq, sorry to interrupt you. Farooq, sorry to interrupt you. There will be a full talk on antigen antibody by from the pathology team. It will be next Saturday. So just be brief about this question. So हमारा पूरा session है, ये बहुत burning सवाल है. So please go ahead.
No, that's fine. I think we should let the pathologist answer this. Let them answer this, and we'll have much more. So in UK, there is rather unreliable data for now. We are only offering as a nation to healthcare professionals. We're not offering to anyone else. I guess in Pakistan, the burning thing is about the convalescent plasma. Therefore, everyone is very keen about the antibodies and antibody levels. But that's absolutely, अगर आप लोगों का एक dedicated session है ना इसके ऊपर, so I think let's leave it to pathologists. We'll wait to hear from them.
Right. Thank you, Dr. Farooq. Dr. Adeel, can you answer this question? how long can we use an N95 mask?
So you can easily use it for a whole day, and you can probably, if you are completely resource limited and there's no supply, you can reuse it the next day. Up to several days is also been reported. लेकिन दो तीन चीजें ख्याल रखें कि the mask is not damaged, the mask is not visibly dirty with the secretions from patients or other materials. So उसको reuse किया जा सकता है for more than one day, up to 3 or 4 days भी use किया जा सकता है. Not ideal, but in situations with an emergency, we can do that.
और उसका जो सरफेस है ना, जैसे दिल भाई ने कहा, तो वो जब आप मास्क उतारने से पहले जब वो आपके मुंह पे लगा हुआ है तो अल्कोहल वाइप से आप उसको बाहर से साफ करके then you wash your hands and then you take it out and you can reuse it. It's fine.
Thank you.
And the दूसरी, sorry मैं भूल गया कि in between days you need to store it properly in a airtight bag or something, कि ये नहीं कि आपने वो ऐसे रखा हुआ है जहाँ पे वो रात को contaminate हो रहा है किसी चीजों से. So put it in a sealed plastic bag type की चीज में where there's no chance of contamination when you're not wearing it.
अच्छा, इसमें एक मैं चीज आपको ऐड कर दूं, हम लोगों पे ना यूके में भी बहुत बुरा वक्त आया हुआ था, हम लोग के पास PPEs नहीं मिल रहे थे. Our government unfortunately didn't take it seriously. We're not much different from you actually. About 2 months ago. So what we used to do at that point, हम लोगों ने ना mask 1, mask 2 और mask 3 कर दिए थे. इसका मतलब क्या है कि जो मास्क मैंने मंडे को यूज किया है और वो मैंने प्लास्टिक कवर में अपनी ड्रॉ में ऑफिस में रख दिया, वो मैं थर्सडे को यूज करूंगा. बिकॉज अभी आपको दिल भाई ने बताया कि आफ्टर क्रीलिंग अगर आपके पास कोई वायरल पार्टिकल रह भी जाता है, so the life of that particle on that surface is about 2 to 3 days. So you have further reduced your risk of exposure by using the same. Do you guys get that? Does that make sense? कि आपके पास अगर 2 मास्क है ना, तो जो मंडे को मास्क यूज किया उसी को ही ट्यूसडे को मत यूज कर लो, जो मास्क नंबर 2 है उसको ट्यूसडे को यूज कर लो और मास्क 1 को वेडनेसडे को निकाल लो या थर्सडे को निकालो. So you've actually given more time for virus not to be alive ex vivo.
Right. Thank you, Dr. Farooq. And is wearing a surgical mask over the N95 mask give any benefit? Will it make the N95 last longer?
Go ahead, Farooq.
No, that's fine. I guess the answer is same.
Yeah. No, it doesn't. I think आपको अपनी थोड़ी तसल्ली हो जाती है. You prevent it from soiling. अगर आपके पास इतनी facilities हैं तो yeah, you can use that, but it doesn't do much in terms of protection from infection.
Thank you. Dr. Adeel, is it mandatory for a healthcare worker to get the PCR done after resolution of symptoms and rejoining work?
हम लोगों ने ये restriction खत्म कर दी है. This is where I have a slight difference with some other colleagues. के our recommendation, which I've given to the governments of Qatar and other places, is and we are actually following that nationwide, that once you are asymptomatic, so this is very important. This is for asymptomatic people only. You have been in isolation for 14 days, then there is no need to do another PCR to come out of isolation. We just send them home. But like Farooq said, we do advise them to stay in home isolation or in more stringent precautions for at least 1 more week.
Right. Is central air conditioning safe in closed buildings? Dr. Adeel,
so I do not know of any cases of transmission via air conditioning units. Maybe someone else has any other experience with that. मेरे knowledge में नहीं है कि कोई ऐसी उससे transmission हुई हो. Professor Altaf, Farooq, have you heard of any cases from air conditioning?
No, not necessarily. What although के जो हमने recently अपने endoscopy units में किया है, to increase the positive ventilation, we've put cardboards onto the windows. वो windows जो खुलती double glazed होती है ना, so there's only one window opens, the other one doesn't. So the one that doesn't open, what we put a cardboard to it, and through that we made a hole. और आप लोगों ने you might have seen कि जो central air conditioning के systems होते हैं ना, they've got huge hose pipes जो buildings के ऊपर run कर रहे होते हैं. So similar kind of hose pipes we have extracted over there, and we're trying to generate pressure air outside. All we're trying to do is dissect. लेकिन ये सिर्फ endoscopy के लिए, वो भी mostly मेरे rooms में, क्योंकि my EUS procedure can last up to an hour and a half. So the director was very kind to me, and he realized that he actually gets exposed for about an hour and a half to an individual who with an aerosol generating procedures. So therefore, otherwise, as Adeel bhai said, I have not really come across air conditioning in its own right have increased the risk.
Dr. Adeel, how many types of COVID have been discovered so far?
There is only one type of COVID that I know of. I think there is this myth going on around type 1 disease, type 2 disease, type 3 disease. Maybe that is what someone is asking. That is an arbitrary differentiation based on severity. There is no real basis to that. What is mild, moderate, severe, कोई भी आप definition जो use करते हैं, validated, you'll be able to use that. There's only one COVID, SARS-CoV-2, which causes COVID-19. हाँ, दूसरे coronaviruses बहुत सारे और हैं. There are 7 of them that cause infection in humans in total. But ये COVID-19 जो is caused by SARS-CoV-2, that there's only one that I know of.
If a patient has recovered clinically, PCR is still positive, is that patient?
So we lost you, Bushra.
Lost, but perhaps you can do it again.
Right. A patient has recovered, Adeel bhai, and the PCR after 14 days is still positive. Is he infectious? What would you advise? Should he extend his isolation, or can he go back to work?
So we do not recommend extending isolation based on just a positive PCR after 14 days, because the chance of that being viable virus is very, very, very small. And we have done some studies, viability studies, to look at that. One way to do that is you can ask the lab, maybe we can ask Chuktai and Akh and other labs to report what we call cycle threshold, as to how many cycles of PCR did it require for it to become positive. And if it is more than 30, then the chance of it being viable virus is almost nil. So in other words, the short answer to that is asymptomatic patient, 14 days in isolation, has stayed as asymptomatic for the last at least 7 days or so. Even if the PCR is positive, that is unlikely to be an infectious virus.
Dr. Adeel, can ivermectin help reduce viral load in a patient with mild to moderate symptoms?
The only studies for ivermectin that I've seen are in vitro studies. I've not seen any major clinical trials for ivermectin right now. There may be one small case series. So right now we are not recommending ivermectin.
What about Dr. Farooq? Sorry, Dr. Adeel, please continue.
No, it was me asking Dr. Farooq, after the dexamethasone study, what are you doing with your patients with moderate to severe disease in your ICUs and HDUs?
So I'll talk about this recovery trial more in about 2-3 days. One part of the talk is purely about treatment, क्योंकि आप लोगों के जो questions पहुंचे थे ना हम लोगों के पास, वो a lot of them are treatment based. कि remdesivir का क्या role है, और tislelizumab का क्या role है, ivermectin, ये सारे. So what we will do, we will cover these inshallah in 3 days time when we do. There's a whole section. लेकिन मैं आपको quickly बता देता हूँ, जो dexamethasone है, इसका जो रोल है वो ऑक्सीजनेटेड और वेंटिलेटेड पेशेंट्स में है. तो प्लीज इसको हमने इतने एंथुसियाज्म के साथ गले नहीं लगाना है कि जैसे ही पेशेंट पॉजिटिव हो जाए तो हमारी प्रिस्क्रिप्शंस पे डेक्सामेथासोन आ जाना चाहिए. दैट इज एक्चुअली नॉट ट्रू. In fact, when we didacted and dissected the information even further, there is some potential harm to the individuals who were mild symptoms or asymptomatic using dexamethasone. So please don't. I will talk in detail. So for now, does dexamethasone help? The answer is yes, but in a very, very specific cohort of individuals, the one who are your severe in the moderate group, वो जो डॉक्टर बुशरा ने आप लोगों के साथ शेयर भी किया होगा, जो flow chart है, or your severe group. But please don't use it for mild symptoms or asymptomatic patients.
And thank you, Farooq. Very important point. Do not use it for outpatients who are I can't emphasize that enough.
Dr. Adeel, does COVID spread by fecal-oral route?
There is no evidence right now. It does not mean this evidence will not change, but as of now, we do not think that it spreads via fecal-oral route, although the virus is often detected in stool for a very long time, as Farooq pointed out. लेकिन common sense ये कहती है कि आप वो toilet precautions general लेनी चाहिए, वो वैसे ही लें कि भाई toilet should be separate if possible, strict hand washing after coming out from the toilet, वो some universal precautions कहते हैं.
This is more of a comment and less of a question. There is the centrally air conditioned buildings it's not about the transmission via air conditioning. It's basically the fact that the air remains inside the room, becomes stale, and and you're breathing into the same air as a possible COVID positive patient is also breathing. So will an open ventilated window be better than an air conditioned environment? This is what do you think?
It might be better, but like I said, there's no evidence of transmission because of that. There was one study in which the investigators looked at how long does aerosols remain in the air. The aerosols can remain in the air for up to 3 or 4 hours or so, and viable virus can be detected. So, wo air conditioning ho ya na ho, you can pick it up through those aerosols anyway. I'm not saying that aerosol transmission hoti hai, but aerosol mein viable virus, it has been detected for up to 3 and 4 hours. But that has nothing to do with air conditioning. That happens with or without air conditioning in the
room. Is it safe to interact with a patient whose lungs are affected, saturation is dropping, but his two swab tests turn out to be negative?
If the risk of, if your pre-test probability is higher that this person has COVID-19, so no, it's not safe. You must take full precautions with full PPE, even if 2 tests are negative. Ek test ki PCR ki positivity sensitivity is about 60 to 70%, maybe a little more if you do the test very thoroughly. If you do 2 tests, it goes up to high 90s. It doesn't become 100% still.
Thank you, Dr. Adeel. For those of the participants who are asking questions about antibody levels and the test that is done, there is an entirely separate session that is soon going to be held. Please make sure that you attend it and you will get your answers. Dr. Adeel, please lay stress upon this. We talked about it in last session also, but there is somebody who has commented that WHO says that asymptomatic cases are not infectious, so there's no need of social distancing. Please clarify it all over again.
So that is not true at all. Maria, who made that comment, is a friend of mine, and we sit on the advisory committee. I mean, she's an employee, but I sit on the advisory committee that she chairs. At that point, there was not enough evidence when she made that comment, and that comment was later retracted. We do not know exactly how many transmissions occur because of asymptomatic carriers, but that number is not 0. So if someone is positive,
you had a quiet word with her afterwards.
So,
Dr. Farooq, a patient has continuous low-grade fever for 3 weeks. All labs are normal. PCR is negative on 11th day. What should this patient do now?
Can we have COVID patients who, in fact, after becoming negative, can have low-grade or some degree of temperature post 14 days? The answer is yes. We're not exactly sure what's the percentage of it, but does that patient remain infective? Again, I think, please remember the 14 days rule. As Adeel bhai said, the viral particles, the number goes considerably down after 14 days, and you are not as infective as you were believed to be in your day 1 of your symptoms. Actually, you start becoming highly infective. There was a study that actually said about 0.7 day before you have full-blown symptoms. and then that risk carries on to day 12. It gradually comes down. Day 13, day 14 is very minimal. अच्छा, क्या उस पेशेंट को टेम्परेचर रह सकता? एंड द आंसर इज यस. देखो, इस चीज को ना आप लोग बिल्कुल इग्नोर मत करो कि, और ये मैं रजिस्ट्रार्स को भी अपने बताता होता हूँ कि टेम्परेचर इज नॉट ओनली द एक्सप्रेशन ऑफ इन्फेक्शन. हमारे बहुत सारे पेशेंट्स हैं जिनको लिम्फोमा का जो पेशेंट है, देयर आर lymphoproliferative disorders जिसमें patients get temperature. That's not because of infection. Why? So we don't actually quite understand this. However, there is a cytokine and there is an IL interleukins response that may well carry on generating certain amount of activity that the body is trying to learn and develop against. And the temperature can carry on. That I don't exactly know whether it's 2 to 3% of the patients with COVID infection that have been found to have long-standing low-grade temperature. But I certainly know that the temperature can last up to 4 weeks, a low-grade temperature. And all you do is just take simple paracetamol. But no, that is no indication. If patient's asymptomatic, breathing uski theek hai, aap chest x-ray karwa chuke ho, koi sign of infection nahi hai, aur bloods uske sare theek hai, there is no suggestion of ongoing infection, secondary bacterial infection, please do not give him antibiotics. Just reassure him कि आपका low grade temperature है, आप hydration को अपनी maintain रखो, आप paracetamol ले सकते हो. अगर आप particularly अगर temperature के साथ आपके जिस्म में दर्द हो रहा है, इसको जिस्म टूटना कहते हैं, it's a very common symptom पाकिस्तान में लोग इसको describe करते हैं. But other than that, I don't think we just need to do anything else. Number 2, post-infectious myalgia, post-viral infection malaise. These two symptoms are actually very, very common. And we all know that malaise, good 10 to 15% of the patients have or do have a low grade temperature. So it's not necessarily a sign of infectivity or sign of ongoing infection. It may just be the sign of whatever has happened in the body and it's just carrying on. But it reassure your patients कि ये ठीक हो जाएगा, इसके लिए घबराएं नहीं. इंजेक्शन एंटीबायोटिक्स के लगवाने की जरूरत नहीं है कि ये ठीक नहीं हो रहा, मुझे बहुत सीवियर इन्फेक्शन है. अगर ब्लड्स ठीक है, चेस्ट एक्सरे ठीक है, it will get better. It might take up to 4 weeks. इतना उसको reassure कर दें ताकि वो पैनिक ना करे.
Dr. Farooq, is there a chance of reinfection?
And so again, this is very poorly understood mechanism. Abhi bhi, the jury is out there. However, there is about 1 to 2% risk, as I understand through the studies, of reinfection. It is possible. What do you think, Adeel bhai?
We do not know that reinfection occurs. पहले जो शुरू में cases हुए थे, we did not understand this PCR positivity for a very long period of time. And people were being PCR positive for 3-4 weeks or so, they said that इसको reinfection हो गया है. अभी तक there is no strong evidence of reinfection, at least in the short term. लेकिन वो एक paper परसों या कल ही publish हुआ है, which has said that immunity may not last as long as we initially thought. जो protective antibodies होती हैं, first of all, the level is very generally low in a good 1/3 to 1/2 of the patients. And that also may wane off very quickly.
One last question. Is there a method by which we can check whether an N95 is working or not?
Yes, it's called fit testing.
Right. That's done by occupational therapists.
Yes.
No, you can do it yourself. देखो यार, आप लोग सारे हंसते हैं, मैं कहता हूँ यूके और पाकिस्तान में ज्यादा फर्क नहीं है, हम लोग ऑलमोस्ट वही करते हैं जो आप लोग करते हो. So we never had that much human resource that we would let. I mean, we cover 1.2 million population, my hospital. There was up, and we have about more than 2,000 medical staff. There was no way that right in the middle of that pandemic, when we were heading towards a peak, कि हम अपने सारे staff को fit test. So basically what you need to do, if you can see my picture here, ये मुझे मेरी nurse ने बताया था, believe it or not. I never had fit test done by a OCU health person. So आप उसको mask को पहनो और आप उसको मुंह पे रखो and then blow into it. If you can see the air coming out, आपको feel हो जाएगा आपकी side से, इधर से, तो आपको पता लग जाएगा this is not really. And then what you then do कि you press it against to make a good seal. That's what you're looking for really. अच्छा इनमें वो हजरात जिनकी दाढ़ी है, they might actually see slight more problems than other individuals. That is why we move on to hoods, because then if you wear hood or ventilator hood, then you really much better than that. But that's all about it really. Fit test, you should do it. Your Oku Health should do it if they can, but if they can't, don't wait for them to come on day 7 and you get yourself exposed for 7 days. Just do it yourself. You can do it.
Professor Riaz has a question. Has there been any study to substantiate claims from few quarters of increased prevalence of typhoid in COVID patients?
I have not seen that so far.
May I just say a brief word about here? We are diagnosing typhoid on the basis of Vidal and Typhi-DOT, which are serological tests. Vidal test has been taken away by most reputed labs about 50 years ago, and Typhi-DOT test was removed from the portfolio of most of the reliable labs about a few years ago, even in Pakistan. So these are not the tests. If you have been exposed in the past, even if you get flu or COVID-19, there will be an immunistic response, and all these non-specific antibodies will rise and give you a positive serological test. It is of no value. Please base your diagnosis on culture and sensitivity. I have not seen a single positive Salmonella culture tests in suspected or confirmed typhoid cases, COVID-19 cases so far.
Thank you, Professor Altaf. We will address any questions that might have been left in our separate question answer session. It's over to you, Dr. Asad.
Assalamu alaikum everybody. Just to tell you कि जो हमारी अगली talk है Tuesday को, Farooq will be taking a full session on question and answers. और काफी सारे questions repeat भी होंगे और उनके ऊपर evidence based answers होंगे. And next Saturday we will have a session on diagnosis, which is antigen and antibody. वो जो debate है आपकी कितनी antibody होनी चाहिए, convalescent plasma का क्या role है. और उसके बाद next week में we have 2 sessions lined up. One is the imaging in COVID-19. So Dr. Najmuddin will be talking about X-rays. मैंने उनसे कहा था कि आप X-ray पे ज़्यादा बताएं क्योंकि हमारी primary care में X-ray use होता है, and of course where to use CT scan, हम उसके बारे में भी बात करेंगे, लेकिन हम primary care practice में X-rays की बात करेंगे. And end of that week हम एंजाइटी के बारे में बात करेंगे. ये वो एंजाइटी है जो बहुत सारे सवालात जनरेट कर रही है और रेपिटेटिव क्वेश्चंस भी जनरेट कर रही है. आखिरी चीज जो मैं आप सब लोगों से रिक्वेस्ट करूंगा, एज वी आर मूविंग अलोंग विद दिस प्रोग्राम, आप में से जो प्राइमरी केयर फिजिशियंस हमारे साथ काम करना चाहते हैं, हमारी गाइडलाइंस जो हमने ऑलरेडी, हमारी कोई चीज हिडन नहीं है, वी कैन शेयर विद यू, और हम और थोड़ा सा डेटा मेंटेन कर सकें तो वो काइंडली मुझसे राब्ता करें. ईमेल्स हैं, एको का सारे नंबर्स आपके पास हैं, सो दैट वी कैन हैव अ ग्रुप टू वी नीड टू फॉलो पेशेंट्स ऑफ कोविड के हम प्राइमरी प्रैक्टिस में जिन कोविड डील कर रहे हैं उनके आउटकम्स क्या हैं. तो ये आप जरूर शेयर करें. सो वी ऑल हैव टू लर्न अ लॉट फ्रॉम दिस एक्सरसाइज. और आखिरी चीज ये है कि वी आर मेकिंग अ डॉक्यूमेंट ऑफ द फ्रीक्वेंटली आस्क्ड क्वेश्चंस. ये सारे क्वेश्चंस जो आप पूछ रहे हैं हम इनको रिटन फॉर्म में लेके आ रहे हैं, और वो डॉक्यूमेंट इंशाल्लाह मेरी कोशिश है कि विद इन अ वीक आप सब लोगों से ईमेल हो जाए, शेयर हो जाए, हमारी वेबसाइट पे या जिस तरह भी हो हम आप तक पहुंचा सकें, ताकि यू कैन गो ओवर दैट डॉक्यूमेंट विद ऑल दोस क्वेश्चंस इन योर माइंड, ताकि वो लिखे हुए हों. एंड ऑफ कोर्स WHO की तरह हम यूटर्न भी ले सकते हैं अगर 1 हफ्ते बाद या 2 हफ्ते बाद कोई गाइडलाइन चेंज हो जाती है. तो इट्स एन इवॉल्विंग सिचुएशन. हम उसके ऊपर जिस हद तक हो सके वी आर ट्राइंग आवर बेस्ट, अगेन फोकसिंग ऑन प्राइमरी केयर फिजिशियंस, जनरल प्रैक्टिस, how to tackle the menace of COVID-19 in Pakistan. Before going over to our administrator, I would like a brief comment from Usman Waheed. He has been instrumental in for an unrestricted educational grant for this program. Usman, if you can say a few words, and then we'll go over to Kiran Amir.
Thank you very much, Dr. Asad. आपको WHO के साथ साथ हुकूमत के भी U-turn का कहना चाहिए था. लेकिन I just wanted to say it's a real privilege to support this wonderful effort जो आपने शुरू किया है, and आपके साथ Professor Altaf Alam, of course, and Dr. Adeel, who always makes time for these sessions, and every time, even if you've heard him many times before, every time you learn something new. And Dr. Farooq, of course, has been a wonderful friend to hepatology in Pakistan, medicine in Pakistan. And in the end, on behalf of Firozans, I'd like to thank all the participants for taking time out. हमें अंदाज़ा है कि ये कितना मुश्किल वक्त है पूरे मुल्क के लिए, और मुल्क और मरीज और तबाही के दरमियान आप लोग ही खड़े हुए हैं. So we salute all of you for your bravery and for your wonderful efforts, and we are there to stand with you in whatever capacity we possibly can. Thank you very much.
Thank you. Thank you. We would like to thank PMA Gujranwala, District Health Authority Gujranwala for their support, and Mr. Usman Waheed of Firozans Laboratories for Unrestricted Educational Grant. Also, I am thankful to our PARSA Health Net Echo team who are working very hard in these difficult times. Our Chairman Chaudhry Suhail Akhtar, Dr. Asad Ali Chaudhry, our Director, Mr. Tabarak Hussain, Secretary PARSA Trust, Dr. Amna, our Facilitator and Echo Lead Payam, Mr. Uzair, our Clinic Coordinator, Mr. Haris, IT Support, and Suleiman. This session, as others, will also be available on our YouTube channel. Allah Hafiz. Uzair, over to you, please.
Thank you very much, ma'am. Till next Tuesday. Allah Hafiz to all of you from Team PARSA Health Net Echo Pakistan. Good night.